Good morning, everybody. Thank you for attending and coming to what I think will be a very informative and engaging session. I'm Greg Sawicki. I'm a pediatric pulmonologist and director of the CF Center for the Pediatric Program at Boston Children's Hospital. So welcome to Boston. Hope you're enjoying your time here as well.
Good morning, everybody. I'm Jamie Woldridge. I'm a pediatric pulmonologist at Rochester, New York. And just as a quick review, this morning we've got a great session lined up. Very briefly, the workshop objectives. We're going to describe the financial and cost burdens faced by people with CF, including the impacts on their quality of life and healthcare utilization. We're also going to explore challenges and facilitators for clinicians and care teams to evaluate and address the financial burden in CF, and also explore the impact of CFTR modulator therapy on financial outcomes in CF.
I know we've been in the session. We will have time for questions at the end of each presenter. Feel free to come up to the mics, but also feel free to use the app to put in questions as you want. And we have time built in, if possible, to have a panel discussion at the end of the session with all of our speakers. And so there may be some time for questions after that. And I do want to just make one quick comment about the titling of this workshop, because I think our group thought long and hard about why we called this financial toxicity. It's a pretty strong term when we think about sort of the wording and the language of what that means. We don't view it as a negative term. We view it as, if we think about it from the medical language, we talk about toxicity of a lot of therapies, whether it be toxicity of the liver, or the kidneys, or other potential adverse effects of any kind of therapies. We recognize that people with CF and their families incur large burdens of therapeutic regimens, not just medications, but equipment, navigating systems, navigating how they find their care. And that can incur a financial cost for people that may actually be a toxicity and a hindrance to their health. And I think we as clinicians and people in CF care teams need to be aware of that. And so we use the language very intentionally. And I encourage you to think about that when you think about how you disseminate and talk about these kind of topics with people who aren't in this room. Because I think the people who come to sessions like this will understand what I just said and will agree with it. But I think there are many colleagues who don't think about it or may not actually think about it as part of their routine interaction in clinical practice. But I think we are at an era right now, and I think we'll hear some really compelling data that suggests that we really do need to pay attention to this, whether you're a physician, a social worker, a dietitian, any other member of the care team, or really if you're part of the healthcare system operating in terms of helping people with CF worldwide.
Okay, and with that, we'll introduce our first speaker. Erica is a senior research scientist at Dartmouth Institute for Health Policy and Clinical Practice at the Gesell Medical School at Dartmouth. Her research interests include understanding how health systems can enhance patient and clinician partnerships, enhance outcomes, and support the delivery of high-value care. She has a particular interest in supporting communication between healthcare professionals and people with chronic and serious illness. She's worked with colleagues at the CF Foundation to explore the experiences of people with CF, their families, and healthcare professionals. And with that, thank you.
All right. Thank you so much for inviting me today to share our preliminary findings from the COST CF survey. The focus of this survey is on exploring financial stressors in daily life and access to care within the CF community. This work has been funded by the Cystic Fibrosis Foundation. So in 2019, the CF Foundation sponsored the Health Insurance Survey, and the focus of this survey was to look at the financial burden of CF care. What they found is that the financial burden is pervasive, is not covered by insurance alone, and significantly impacts access to care. So given the COVID-19 pandemic and the availability or widespread availability of elexacaftor, tezacaftor, ivacaftor, the CF Foundation again wished to look at the cost of care and the financial impact that it brings. So they've sponsored the COST CF survey, which is cystic fibrosis outcomes, social needs, and trade-offs due to coverage and financial burden. And the role of this survey is to understand how the cost of CF care affect daily living, access to healthcare services, and how CF care teams identify and address financial needs for people with CF. So the COST CF survey was co-designed by people with CF, caregivers of children with CF, clinicians, and researchers, many of whom are here in the room today. So it came from people from the Dartmouth Institute, Boston Children's Hospital of Philadelphia, University of Virginia, the Cystic Fibrosis Foundation, University of California, San Francisco, University of Southern California, University of Michigan, Oklahoma State University, and adults with CF and parents of children with CF. The survey was intended to be taken by adults with CF, caregivers of children with CF, caregivers or spouses of adults with CF, and CF care team members, and was available in both English and Spanish. It was in the field this spring from late February to early May, and took about a little over 20 minutes for people with CF and care team members to complete. We received 1,400 or nearly 1,400 responses. The vast majority of them were from people with CF, with almost 250 from care team members. So the characteristics of our responses, about a third were parents of children with CF. A little less than a third were from young adults, those who are ages 18 to 35, and another third from adults ages 35 and older. Most identified as non-Hispanic white, and 5% were dual eligible for Medicare and Medicaid, 14% for Medicare, 15% for Medicaid, and 63% from private insurance. Our care team members were nearly equally split between adult and pediatric care centers, with a small number from affiliate centers. Providers were also equally split between social workers and medical providers, with about 12% from pharmacists and 31% from other provider types like nurses, therapists, dietitians, mental health coordinators, and others. The analyses that I'm going to present today are broken up by income level as defined by the federal poverty level guidelines. So these are based on household size and income, and it's used to determine eligibility for federal programs and benefits. So what I've tried to do is give a little bit of breakdown so you can put this into context of a family of four and how this relates in terms of income. So we had 7% who were under 100% of the federal poverty level. And for a family of four, that's less than $30,000 of annual income. We had in the 101 to 300% FPL, we had 29%. That's less than $90,000 for annual income. In the 301 to 500,000, we had 28% of the population, so that's less than $120,000 annually. And the fourth bucket, which was our biggest, was the greater than 500% federal poverty level, so again, more than $120,000. So as you would expect, there are some significant differences across these income level buckets. And this is probably most notable in the types of insurance, which is also probably most expected. But what you see is in that lowest bucket, these people are primarily funded by governmental insurance. So that's indicated by the blue, purple, and red buckets, who are dual eligible Medicaid or Medicare recipients. That group has a much smaller proportion of people with private insurance. Okay, so the first area we wanted to look at is the ability to afford and access healthcare services. We find is that paying for CF care is difficult for many people with CF, and it's the most difficult for those people in the 300% or lower federal poverty level areas, but affecting nearly half of that lowest income group. And within these different income groups, there are different things that they have difficulty paying for. So the most common challenges in the lowest income bracket is paying for things like vitamins and oral supplements, prescription medications, hospitalizations, and imaging. In that next blue bucket, the most difficulty they have is around hospitalizations, G-tube supplies, and subspecialty visits. And in the red bucket of the 301 to 500% FPL, it's around hospitalizations, imaging, subspecialty visits, and prescription meds. And in the blue bucket of the greater than 500% FPL, none of the categories that we looked at affected more than 5% of people with CF. So then moving on to insurance coverage, it also is difficult for many people with CF, affecting, it has the biggest hit in those middle income brackets that we're looking at. So the people with 101 to 500% FPL. And the most common challenges navigating insurance don't actually differ across any of our 4 buckets, so they affect everyone equally. And those are understanding what I'll have to pay for services, resolving pharmacy issues, and getting access to medications, things like pre-authorizations or verifying benefits. And then impact-wise, up to half of people with CF delay or skip care to save money. And this really impacts all of those groups pretty heavily who are under 500%, and even a quarter of people in the highest income brackets. The most common reasons to delay or skip care, again, didn't differ across our categories, but look at the cost of copays, insurance denials, and the inability to miss work. So we wanted to move on and look at, well, what do we do about it? And so we looked at the role of the care team in addressing financial needs and access to financial resources. And looked at this both from the perspective of people with CF and care team members. So nearly 2/3 or more of people with CF think that CF care team members often or always have a role in discussing the costs of care. So there's generally pretty heavy support on the patient and family side. And on the care team side, which you'll hear more about in a little bit from Ryan, we have 83% say that supporting people with CF to address financial needs related to CF care should be a standard part of CF care. So those are the people who said this should often or always be the case. And then we looked at comfort discussing costs of care. So would people actually be comfortable even if they have a role? And this varied across different income levels, but I would say that a little over half of people were very comfortable or comfortable discussing financial concerns with their CF care team. And there was another big bucket who were somewhat comfortable. The lowest level of comfort was in that bucket was just above Medicaid eligibility, so the 101 to 300% FPL. And this question is 1/5 of care team members were often or always concerned that people with CF would feel uncomfortable. So it's a little bit flipped, but it recognizes this fact that there are definitely the people who do feel uncomfortable talking about financial needs. And then our final look was to look at knowledge about where to find resources. And nearly 40% of people with CF with the lowest income did not know where to find financial resources. And this drops off based on income levels. And interestingly, nearly 40% of physicians said that they never or rarely knew where to find resources to address financial needs of people with CF. And notably, you'll see that social workers were the least likely to say that they didn't know where to go, followed by pharmacists. All right, and the final section that we looked at related to the greatest needs related to costs of CF care for both people with CF and for care team members. And this is based on some open-ended questions at the end of the survey. The 3 biggest buckets that people with CF identified as needs were insurance coverage and navigation. So this 34-year-old woman said, I need to know how to choose the best plan and how to work within the rules to get the best out of them. The second area was kind of help addressing financial needs. So this 66-year-old man said, I need to be given the knowledge of different programs and resources that are available. And the third was lower healthcare cost. So this man said, I need lower cost of medications. Living with CF is now a long game. Lower medication costs is the only sustainable approach. And then from the care team side, we saw some similarities and some differences. So our care team members primarily identified the need for help addressing financial needs as well. So I need resources to give to patients when they face financial problems, was from one physician. This social worker identified this kind of idea around processes and standardization. So how do I do this? I need to have more time in and out of clinic dedicated to address these needs. And the final bucket, kind of the third biggest category, was around care team role. So I need more team members to help take on some of these responsibilities. So our survey has a number of strengths and limitations that we should acknowledge. First, in terms of strengths, it was co-designed by a really great group of interdisciplinary people who were representing clinicians, researchers, adults with CF, and parents of children with CF. And we had a really robust process in identifying the areas that mattered most to people and that they would be most interested in hearing more about. We also had a large number of responses, so we're really thankful for people to contribute all that time to put in these survey responses. In terms of limitations, this is self-reported data, and has limitations associated with that. And the sample is not fully representative of the larger population of people with CF. This is still, these are still really early preliminary findings, and the work that we're doing right now is to think about how do we best weight this data and what types of analyses do we weight and do we not weight. None of these analyses were weighted. So in terms of the summary and next steps, first of all, thinking about the ability to afford care. Paying for CF care costs and insurance is difficult for many people with CF. And half have challenges with insurance coverage, often regardless of income level, and half of people with CF delay or skip care to save money. In terms of financial support and resources, most people think that CF care team members have a role in discussing costs of care, and many are comfortable discussing these issues, but not all. People with CF need support with insurance, addressing financial needs and lower care costs, and clinicians need resources to address financial needs and the time and staff to do so. And just to call out, the social workers are most likely to know where to find these resources to support financial needs. Looking ahead, our survey findings, we hope to inform kind of future research priorities, care and programmatic offerings, and advocacy and policy efforts. So I just want to close with a thanks to our study team members, and then also a thanks to the people with CF, the caregivers of children with CF, parents, spouses and caregivers of adults, and the CF care team members who took the time to participate in this study.
We have a few minutes for questions.
So it's a great talk. Did you have any data in the survey on financial toxicity as it relates to actual jobs and professions? So in other words, how many patients with CF, for example, because there's been some data, I think it was out of Chicago, that looked at this in a separate survey of failure with patients who won't, for example, leave their job or look for a new job because they're afraid of losing their insurance, moving or living in specific areas. And I can't remember if it was from the Cost CF survey or if this was a different study.
So that we do have a question. This is actually a huge survey. So
Sorry.
No. This is good. This is the first time that we've shared any of the data from Cost CF. So it's a really big survey, and it pulls from a lot of different sources in terms of the questions that we put together. Some of them mimicked the questions, or were very similar from the questions that were in the 2019 survey, because we wanted to be able to draw comparisons. But we do have a question looking at, exactly what you're saying. So do people leave or stay in a job? Do people stay in their job because of their fear of losing insurance? There's a whole bunch of reasons that we haven't yet explored it, but we'll hope that this will kind of be coming out in future presentations.
If I could just address that question too. The 2019 HIS survey did have a question or a couple of questions surrounding job lock. And we actually did some analyses looking at that and found that there was a higher proportion of people with job lock in the CF population compared to other chronic disease entities.
So maybe it was the 2019 data I was wondering about, but we have no idea if that's changed or not yet.
And that's one of the benefits that we have of being able to have similar questions between the 2019 survey and the 2024 survey. So we will be looking at those comparisons.
Erica, that's wonderful data. Obviously, by its nature, very U.S.-centric. I was wondering if you have any comparisons to toxicity of cost in areas that have other healthcare insurance plans, national insurance, that sort of thing, and how the cost is an issue for people in other countries.
Yeah. So far, again, we're super early in evaluating kind of the responses to this survey. But part of what we did in developing it was to look at what other surveys we could find internationally to be able to draw questions from. So we do similar questions from the Canadian survey that's recently been completed, as well as a UK survey that's recently been completed. We haven't looked at the comparisons yet, but that's part of why we did these kind of brought in questions from those surveys, so we'd be able to have a similarity across them.
Hey, good morning. And I'm going to apologize for coming in late and say that if you've already answered this question a bit before, I'm going to be suitably embarrassed. But just to ask specifically on this, you're looking at the numbers of people that were under financial duress as a result of these costs, and that they were self-rationing access to care. Is that something where you're seeing patients specifically not being able to access timely modulator treatment? Are they reducing the like frequency with which they're taking modulators to stretch out their doses, or are they not being able to access modulators at all? Did you see any examples of that? Thank you.
Yeah, so we did have that question in there that you saw about half of people are delaying or skipping care. That was a kind of an aggregate question. So we had about 10 different types of care that they might delay or skip. And that says, was any of these areas something that you delayed or skipped? We haven't looked specifically at, again, we haven't dove down into those specific areas yet. Olivia might be able to answer that more fully, but I'll let her respond to that.
I will say we did have one question about people in modulator status for those who are eligible and not currently taking. There was a follow-up question on why is insurance or financial reasons the reason you're not currently taking. I think it was about 1 in 10 in the weighted data, but I might be misspeaking, but that is something we're going to look into.
And I just want to add, Brian and others, so the our Canadian colleagues did publish in August of this year a study on socioeconomic burden of CF in Canada. Actually, I'm just looking at the abstract now, but you can find it, but that out-of-pocket costs represented 20% of all costs incurred in people in Canada as reported. So this is not a U.S.-centric issue. We know that. The other question, and then we'll wrap up around that, we know that the United States is not a monolith. We know that there are regional differences in Medicaid and access to not just Medicaid or government-sponsored insurance, but what availability of private plans may or may not be. So do you have plans or have you looked at regional differences?
Oh, so we have the ability to, as you know, we are just really getting started in looking at this, but we have the ability to, we did ask where people we asked the zip code, so we have the ability to bring those together into regional areas. And I think the cool thing here is I was talking to Enid, who's one of the co-investigators in the study, and there are so many different studies that can come out of this because this database is so rich. And so what we're really going to be looking for are kind of the questions you're asking right now. How does this compare to this? What happens if you do this? We can answer a lot of these questions. We can answer this regional variation question to some extent based on what we're seeing because of the large size of the sample. So,
Thank you.
yep, thank you.
So to continue this conversation, actually picking up on the themes that we just talked about, is Heather Boas, pediatric pulmonologist at the Children's Hospital of Philadelphia.
Thank you. Well, good morning, everyone. Thanks for joining us for this session, and thank you, Dr. Sawicki and Dr. Woodridge, for inviting me to present this data. The only disclosure is that I do have grant funding from the CF Foundation. So just to start off with a little bit of background about this survey and this study. So I think as all of us in this room know at this point, CFTR modulator therapy has been truly transformative for so many people with CF who are eligible for those therapies. I don't have to go into all of the medical benefits here. So improved lung function, fewer hospitalizations, improved life expectancy, et cetera, et cetera. But we don't really have a lot of data on how these modulator therapies have impacted the financial concerns of people with CF or how they impact the basic life or daily needs of people with CF. It's also important to note that there are still 8% of people with CF who are not eligible for modulator therapies. There's another 5 to 10% of people who are not prescribed who are not prescribed these therapies for various reasons, or were on a therapy and discontinued for various reasons. And so we also don't fully understand the financial concerns of these groups either. And so that was really the objective of this study, to really examine this relationship more closely, to look at how CFTR modulator therapies have impacted the financial well-being of people with CF. And so to do this, we use data from the Wellness in the Modulator Era survey, or the WellMe survey for short. This survey had an overall goal of understanding the impact of modulator therapies on the quality of life of people with CF. So the overall methods and the results of the WellMe survey were recently published in JCF this summer. I'll briefly review some of the methods. It was fielded by the CF Foundation in the summer of 2022. The survey was distributed to adults with CF and parents of children with CF, and it was distributed via community voice, emails, social media, through care centers, and it was open to all people with CF, regardless of whether they had ever been on modulator therapy. The survey questions were divided into these 5 domains that you see listed here. All of these were related to quality of life. But for our study, our focus was on this 4th one, daily living and basic life needs. Respondents were asked to describe their household financial situation. They were asked to describe their worry about financial problems. They were asked to rate changes in financial well-being for people who were on modulator therapy. This was changes since starting a modulator. For those that had never been on a modulator, these were changes within the last 12 months. People who were on modulator therapy were also asked about changes in work or school, changes in financial planning, and changes in cost of living. And they rated these on a scale of much worse to much better. They were also given an opportunity to include free text responses with additional comments. So our analysis included data from 900 respondents. This was 580 adults with CF and 320 caregivers of children with CF. We used descriptive statistics, and we coded the free text responses thematically for analysis. So looking into our results. What you're going to see on the next couple of slides here are the different characteristics of the survey respondents. And what you can see is that each of the columns, they're broken down into self-described financial status. So those that felt that they were living comfortably, those who felt that they were meeting their basic needs with some left over, those that felt that they were just meeting their basic needs, and those that had not enough to meet their basic expenses. And what you see is that the percentages, which are in parentheses, those are for each of those columns, so the percentage of each of those categories. So what I'll first bring your attention to is these numbers in the top row here. What you can see is that actually the majority of respondents either lived comfortably or had a little bit left over. This was actually about 80% of our cohort. I'll just point out that those who were not able to meet their basic expenses tended to be slightly older. A higher proportion of our respondents overall were female, but there was no significant difference in gender across financial status, no significant difference in race or ethnicity. And what you see here is the financial status broken down by insurance status. And so what you can see is that this group here with private insurance was most likely to live comfortably or to have a little bit left over. And those that struggled more financially were more likely to be on Medicaid. Here we see how financial status is associated with severity of illness. So this is based on self-reported FEV1, hospitalizations, or IV antibiotic requirements within the last 12 months. And both of these categories were statistically significant. So what you can see here is that this group with the highest lung function, so this is based on self-reported percent predicted FEV1, were more likely to live comfortably or to have some left over. The group with the lowest lung function was worse off financially. And this group was also more likely to require hospitalization or IV antibiotics as compared to the group that lived comfortably. So it is important to mention here that both FEV1 and hospitalizations or antibiotic use, both of these were self-reported, so they're certainly subject to recall bias. The other thing I want to point out here is that some of the numbers in some of these categories are quite small. So particularly this category of those who did not have enough to meet their basic expenses. But I still feel like this is important to report and note. So what you see here is financial status broken down by modulator status. So each of these chunks of bar graphs are those same financial categories that we just looked at: living comfortably, meeting their expenses with some left over, just meeting or not enough. And then what you see here is that the blue columns represent those who are currently taking a modulator. Orange is those who are no longer taking a modulator but had previously been on modulator therapy. And green represents those who had never been on modulator therapy. So first I'll bring your attention to this first category on the left. So what you see here is that among those living comfortably, the majority were taking modulators. This is about 80%. And you see a similar pattern in the next grouping, which is those that had a little bit left over. But by the time you get to this last category, the group that felt that they did not have enough to even meet their basic expenses, now you see a much larger proportion, nearly half, who were either no longer taking a modulator or had never been on modulator therapy. Now, if we look at changes in financial well-being, so again, for people who were currently taking a modulator or had previously been on modulator therapy, this question was asked of changes since starting a modulator. For those who had never been on modulator therapy, these were changes within the last 12 months. So what you see in the legend there on the right is that they were given a scale of much worse to much better. No change is the gray in the middle. And so here, the majority of respondents, regardless of whether or not they had ever been on a modulator, felt that they had no change in their financial well-being. But there was also a large number of people who felt that their financial status was worse. And in particular, nearly a third of the group who had never taken a modulator felt that they were either somewhat worse or much worse than they had been in the 12 months prior. This figure here shows some of the changes in daily living for those who were currently taking a modulator. Again, you see that the majority of respondents did not experience any changes, but a few things that I do want to highlight here. Categories where people felt that they were likely to feel worse included medical costs, transportation, ability to pay for food, ability to pay for housing, a lot of things that were related to cost. One thing to note is that a lot of these categories are not unique to CF or to modulator status. Things like transportation, food, and housing, these are things that many Americans struggle with, but it's an important reminder that people with CF also struggle with these aspects of daily living. On a more optimistic note, if you look at the bottom right area of the figure, 36% of people with CF on modulator therapy missed less days of work or school. Nearly a third felt positive changes at work. 21% had more interest in planning major life expenses. There was improvement in school performance, ability to plan for retirement, ability to attend college or a tech school. So many of these areas of improvement were related to work, school, and future planning. And finally, we analyzed the free text responses. And the free text was given as an option to all respondents, regardless of whether or not they were on a modulator. And what we saw were several themes that emerged, and I'll highlight a few here. We found that many respondents mentioned positive experiences related to food related to school or work, similar to what we just saw in that last figure. People expressed hopes and fears related more to cost of living, ability to pay for basic needs, medical bills, insurance. And then finally, we saw this new theme of new challenges and concerns with planning for the future. So many people had not considered long-term and retirement planning prior to being on modulator therapy. So just to highlight a few of these free text responses, one of the themes we saw was that many people mentioned the ability to live a, quote, normal life, like this 28-year-old woman who said, my FEV1 and quality of life has greatly improved. I've returned to work full-time, and I'm able to lead a normal life. This parent expressed concerns about insurance cost and medication. I'm always worried insurance will drop us because of the expense of Trikafta. The price of this drug is criminal. One thing to note about this quote is that you can see that this person self-defined as living comfortably, and they are still very concerned. This parent talked about improvements in their son's school performance. He's doing much better at school because he's not missing a lot of school due to Trikafta. He's not napping all the time. And this man expressed concerns about retirement and future planning. He said, retirement concerns. I have no retirement plan because I wasn't expected to live into retirement. Another theme that we saw was people describing their career goals, some of their hopes and goals. We found a lot of parents describing the career goals of their children. So I wanted to highlight a few of those here as well. He hopes to become an NBA player, but realistically, he's thinking of a career as a doctor of physical therapy. Short term, he hopes to make the high school basketball team. My child wants to become a veterinarian. It feels like she can definitely keep up now. He wants to be a park ranger or a cartoonist. To be a doctor or EMT. She's only 3, but has expressed she wants to save people's lives. He wants to be a police officer when he grows up to save people and catch bad guys. He wants to be a dad and a mathematician. She wants to be a nurse or be able to help others with CF. So I really wanted to kind of end talking about the results here with this positive note. For me personally, this was one of my favorite aspects of looking at the data and looking at these results, reading all of these hopes and dreams and career goals. To me, these quotes capture so much optimism and joy and hope. To me, this is why we do what we do. And I think that our goal really needs to be to make sure that all people with CF can have these hopes and dreams. Oh, thank you. Thank you. There were, of course, a few limitations to this study that I should mention. So our survey population was not representative of the overall CF population. We don't have a lot of information, just given the nature of the survey, of exactly who it went out to, but it was certainly subject to selection bias as far as who responded. Also, the information on the clinical status and the clinical information that we have is really limited because all of this was self-reported and subjective. So just to summarize and bring it all together, we know that there are so many medical benefits of modulator therapies, but many people with CF still face financial concerns. And many of these concerns surround medical costs and insurance. Those who were more likely to have worsening financial concerns were also more likely to not be on modulator therapy. Another new theme was that people with CF expressed new concerns about planning for the future. And there continues to be a need for care teams to discuss and address, when possible, these concerns of people with CF regarding their financial stress and ability to meet their basic life needs. And I think we have a lot of work to do in the future to further understand and address these financial concerns and the cost burden of people with CF. So I'll end just by acknowledging all the adults with CF, parents of children with CF who participated in this study and the survey, the many people who helped develop the WellMe survey. You can see their names are listed here. My co-authors who helped with this abstract and helped put everything together, also listed here. And of course, the CF Foundation for the grant funding that they provided us. And with that, I'm happy to take any questions and looking forward to the discussion.
We do have a few minutes for questions. I think Heather thanks you for a fantastic talk.
I do. Thank you.
Again, I'll ask the question about regionalism here. Was there a way to look at whether people were reporting things differently depending on where they lived?
Yeah, that's a great question and an excellent point. That was not something that we looked at specifically in the study. I don't know that we have the ability to look at that. We didn't collect data on zip code or region, but it is an excellent point that there are those differences.
I don't realize how short I am until I get up there. So I helped with a qualitative study for Dr. Sawicki on exploring attitudes towards nutrition and the cost of food. Oh my goodness, it came up over and over again, and we kept trying. Same thing, we were trying to really parse out. Well, what about people who can afford and versus people who can't? And it was overwhelmingly, to your point, regardless, because at the end of the day, it's a high calorie, high fat, and you have to make sure you're eating healthy food. So I just wanted to emphasize that what you're finding in your survey is coming out in our qualitative work as well.
Yeah.
So thank you.
Thank you. Yeah, we didn't ask any specific questions regarding food or access to food, but that was definitely a theme that we saw recurring, that people kept bringing that up again and again.
Hello. I just want to start by thanking the CF Foundation for having this subject discussed so prominently at this event. That is really, really important, I think, for the well-being of people around the planet with cystic fibrosis. Picking up on the theme from the free text, particularly the person who thought that the price of the modulators is criminal, I noticed a few months ago that the Prescription Drug Affordability Board in Colorado determined that the price of Trikafta is affordable. And one of the reasons they did that, I think, is that the drug company and its apologists, well, the drug company openly threatened to remove Trikafta from being available in Colorado. And I think that freaked out a lot of CF families. And so my question to you is, do you think that drug company propaganda is affecting the responses that you're getting to surveys like the one that you've been doing?
Thank you. I mean, it's a great question. It's such an interesting point. I don't know if I can speak specifically to the propaganda, but I will say is that it was such a prominent theme that we saw in our survey respondents, and it was regardless of their financial status, regardless of their insurance status. As we saw in the one quote, the woman who said that she was living comfortably, it was still a very real concern for her. And so even people that were living comfortably, that had insurance coverage, that's a very strong concern, is that they're going to lose that coverage, that something's going to change, and that they will no longer be able to afford that medication.
Hi, Samuel Nasser from University of Michigan. Beautiful work. And actually, back to the question was raised about the food. So I work with a lot of the Egyptian population, and I'm lobbying. A lot of them are undernourished, like most of them. Mm-hmm. So we're lobbying for a high-calorie diet. We're lobbying for appetite stimulant. And one of the nutrition doctors that's visiting with me now said to me, okay, if we give them the appetite stimulants, they can't afford the food. So, like, what to do about that? So it's really a very interesting point that she raised. It's like we're afraid to give it because then they cannot afford to feed the kids when they get more hungry. But
yeah, thank you. That's an excellent point.
Hi. I was just curious if you found in the data that the ending of the public health emergency and now that we are full swing into redeterminations for Medicaid again impacted your data as those populations who may have relied on those services and are now ineligible may be feeling that worsening condition.
Yeah, I mean, it's not something that we looked at specifically, so I don't know if we can know just how much that may have impacted or not. But yeah, it's a great point.
Thank you.
I don't know how much more time you have, but I thought that was actually a really great question because my family fell into that category. So it was something we were really nervous about. So I can't remember if you totally went back and answered that. So you had one of the questions on there about those who could qualify for Trikafta but aren't currently taking it and the reasons why. I can't remember if you had actually said where they fell on, if it was because of financial reasons or because of not prescribed. I don't know if that was...
Yeah, as far as why they were no longer on a modulator.
Kind of what like the answers to some of those were.
Right. So we didn't look at that specifically. So it was just whether or not they had ever been on a modulator or not. And then if they weren't, we didn't further go into what those reasons were for not being on it.
Okay, because I just thought that was really interesting because clearly what you found in this study, early study that you probably will do more on and stuff as well, is that those who were on it seem to be faring better financially. Mm-hmm. And so if a majority, I would just be curious if their reasoning was a financial burden was one of the reasons why they weren't on it, but yet when you're on it, you benefit better financially. And if that's just something that maybe we need to continue to draw more attention to, that the fact that our lower income populations are significantly less able to access this medication, and also keeping them in this bracket longer when actually this could potentially benefit their financial situation if they were on it. So really interested to hear about that.
Yeah. So I can just comment really briefly on that since we was involved in the larger WellMe, and the primary reason for people being in that bucket of no longer taking it was side effects. So that's really what drove most of those people out. There was a small proportion, kind of like Olivia mentioned in the cost CF, that were on, like, couldn't do it for financial reasons, but really quite small compared to the impact of side effects.
Thank you for clarifying that. Yeah. Thank you.
Two excellent speakers so far. Next is Ryan Perkins. Ryan is a adult and pediatric pulmonologist, quite ambitious, at Boston Children's and Brigham and Women's Hospital. He's an instructor of pediatrics at Harvard Medical School. And he's also a recent graduate of the Harvard Public Health Services Research Fellowship, and his research interests focus on value-based healthcare, innovative care delivery models, and the implications of insurance on the clinical and financial outcomes of people with CF.
Thank you, Dr. Woolridge and Dr. Sawicki, for the invitation to be here today. And I'm really excited to be able to talk to you about some of my research looking at clinician perspectives and some of their practice patterns related to cost of care discussions. And so I have no disclosures related to my presentation today. As we've heard throughout this session, and as probably all of us in the room know, the cost of care for people with CF is high. And unfortunately, as a result, many people experience financial toxicity due to the care. We've heard today, and I think we all know from the general population, that many of us as patients want to hear about cost from our primary care physicians. But unfortunately, in surveys, we find that only about 30% of the time are these conversations actually occurring. And we've learned from some of the studies today that our patients actually do want to engage in these conversations, but the frequency and how often this is actually occurring in our clinics is really unknown. And so that was the genesis for our project. And so the objectives of our study were twofold. First, we wanted to evaluate current cost discussion patterns amongst CF multidisciplinary clinicians, and we hypothesized that these cost discussions are occurring infrequently in our clinics. Secondly, we wanted to examine multidisciplinary clinician attitudes and perceptions surrounding cost discussions. And again, we hypothesized that clinicians likely feel that these discussions are important, but maybe feel uncomfortable with leading these discussions during clinic visits. And so our study was a national cross-sectional survey, and we recruited U.S. multidisciplinary CF care team members from across the U.S. We broadly defined clinicians as anyone who engaged as part of the multidisciplinary CF care team, so not just physicians. We distributed REDCap survey links to individual clinicians using CFF listservs, and these listservs were affiliated with CF care centers, and this survey was in the field from September to November of 2023. The survey included several different measures. There were 11 questions that sought to characterize demographics of the clinicians, 10 questions that sought to characterize current practice patterns surrounding cost and financial discussions, a matrix of 16 questions that assessed clinicians' attitudes and perceptions with cost and financial discussions, and 9 questions assessing barriers to having these conversations. Additionally, there were an opportunity for open-ended responses at the end of the survey. From an analysis perspective, we used descriptive statistics to describe our cohort, and we elected to categorize clinicians really into 3 buckets. One, prescribing clinicians, which I'll abbreviate as PC for the remainder of the talk, but this included physicians, nurse practitioners, and physician's assistants. The second group was social workers, and the third were the remaining clinician disciplines like registered nurses or our pharmacists, physical therapists, or respiratory therapists. We then utilized chi-square testing to evaluate for differences between these groups. We had 192 total respondents to our survey, and some of the key clinician demographics are presented here in this table. We see that we had roughly 30% of respondents that identified as prescribing clinicians, another 30% as social workers, and 41% as other clinician disciplines. We had a pretty even balance between clinicians identifying as adult or pediatric providers, with roughly 40% respectively. When considering the amount of time that we had allotted for routine clinic appointments, 54% reported having 60 minutes or less for their clinic visits. And in considering the longitudinal care practice model, just over half identified one prescribing clinician that followed patients longitudinally. In considering the regional variation from where our respondents were from, we had slightly more respondents from the South and from the Midwest in comparison to the Northeast and the West. So after our demographics questions, we first asked clinicians if conversations were to occur in the clinic, which clinician subtypes would be most appropriate to have these discussions. And overwhelmingly, we saw that over 90% of respondents identified, not surprisingly, social workers, but also prescribing clinicians as the most appropriate disciplines. I do think it's worth noting, though, that all other clinician disciplines were also deemed as appropriate to have cost conversations. So everyone can and should be engaging in these. Given that over 90% of clinicians did identify social workers and prescribing clinicians, subsequent analyses looked for differences between these two groups. We then asked clinicians about their perceptions with discussing cost in clinic. 80% of respondents felt that clinicians should discuss cost of care. However, when we looked at the different groups, we found that there were differences. 90% of social workers felt that clinicians should be engaged in discussing these costs, compared to just 2/3 of prescribing clinicians. We then asked clinicians what their practice patterns were for discussing cost over the last year. Roughly just over 50% of respondents reported that they'd had a conversation with patients about overall cost of care in the last year. And again, when we looked at differences by groups, we found that roughly 3/4 of social workers had engaged in a conversation compared to 44% of prescribing clinicians. We then wondered, well, could comfort be impacting the ability to have some of these conversations? So we asked clinicians about their comfort level with having these discussions. 43% of respondents endorsed that they felt somewhat comfortable or comfortable discussing the overall costs of CF care. And again, we see a similar trend between social workers and prescribing clinicians, with roughly 2/3 of social workers expressing comfort compared to about 1/3 of prescribing clinicians. We then ask about comfort level with discussing out-of-pocket cost, and we found that just under half of respondents endorsed feeling somewhat comfortable or comfortable discussing out-of-pocket costs. Again, roughly 3/4 of social workers felt comfortable compared to just under half of prescribing clinicians. We then asked clinicians, what are some potential barriers that may be limiting having these conversations with our patients in clinic? And there were really three themes that emerged. Roughly 75% of respondents identified that lack of time during visits was a big barrier to conversations. 74% endorsed a lack of knowledge about some of these topics. And then roughly 2/3 felt just sort of overall uncomfortable with having these conversations. Notably, just under half identified concerns that patients wouldn't feel comfortable having these conversations as well. Now, unfortunately, when you think about cost and how healthcare is financed in the US, it's difficult to separate cost and health insurance. So we did ask similar questions of our respondents about health insurance. Initially, we asked questions about their discussion practices over the last year, and nearly 3/4 of respondents reported having a conversation surrounding components of health insurance. So this may be things like monthly premiums or co-payments or co-insurance, out-of-pocket maximums. Again, when we looked at differences by groups, we found that nearly all social workers had engaged in a conversation, but only 44% of prescribing clinicians. When considering whether patients had met their annual deductible, 59% of respondents had engaged in a conversation with patients surrounding this. And again, we see similar differences between social workers and prescribing clinicians. We then ask our respondents, if this information is important to them, what role should you be playing in providing education about health insurance to our patients? 70% of respondents felt that clinicians should play a role in teaching about health insurance to our patients. And again, there were divides between social workers and prescribing clinicians. 83% of social workers felt that this was important compared to just over half of prescribing clinicians. We then assessed comfort level with discussing health insurance topics. Roughly 40% of respondents reported that they felt comfortable discussing any of the components of health insurance with their patients. And I think notably, only half of social workers expressed being somewhat comfortable or comfortable discussing this, and only a quarter of prescribing clinicians. We also ask about comfort level with providing education to our patients, and 43% of respondents did endorse feeling somewhat comfortable or comfortable. And again, the similar distribution and response rate between social workers and prescribing clinicians. We then looked at some of the comments at the end of our survey, and I thought several of them were particularly enlightening given some of the responses that we've seen, and I selected a smattering of those to show you here. One respondent wrote, "This information and education falls on social work. However, many social workers are not versed in insurance." A second respondent wrote, "As a social worker, I feel intimidated by the idea of discussing insurance plans with patients." And a third respondent wrote, "This often falls on social work. However, social work is truly a clinical provider. Insurance and financial matters are not our specialty. A jack of all trades is a master of none." Another respondent wrote that, "Although these topics are important, I'm not really sure whose plate this falls on. To be honest, everyone is already stretched so thin." And finally, a respondent wrote, "Unless a patient addresses a concern first, it's not well assessed by any other team members, although it affects every aspect of a patient's care. Every team member should be concerned about this." In conclusion, most CF clinicians did perceive cost discussions as being important, although these conversations are not occurring consistently in our clinics. Over half of clinicians reported feeling uncomfortable discussing aspects of cost, and unfortunately, insurance discussions remain a significant concern for many clinicians. I do want to say, though, that the CFF has multiple resources that are available to help in engaging in these conversations, and so I want to highlight two of them today. One, there's a beautiful primer that is a discussion aid about discussing costs of care in CF, and it really gives a nice outline about how to sort of set the stage and things to consider in having these conversations. Additionally, there's a nice health insurance index that provides opportunities for learning about insurance, about how one acquires coverage, how to talk about costs, and then some pertinent studies about health insurance that have informed some of the work that we've been doing. And if you're wondering where you can acquire these, on the NACFC app, there's a CFF resources page that both of these can be found. So I think this study lends itself to thinking about, well, what do we do about this in the future? And we have these wonderful decision aids that are out there. I think this information, highlights opportunities for intervention development to help address these areas where clinicians may not feel comfortable in having these conversations, and also to help improve the overall knowledge base. And I think this also sort of highlights the need for ongoing research around insurance and cost. And in particular, I was fortunate to recently be awarded a Schwachman, and some of my Schwachman Award research has been in this area, and really thinking about what are some of the attributes of health plans that are important to patients when they're picking their health plan. Really sort of diving into health plans, linking them to actual EMR and outcome data, as well as financial data. And then thinking about, within different health plans, are there differences in utilization, and does that translate into differences in costs for our patient population? And so with that, I would like to give a special thanks to Dr. Sawicki, who's my research mentor, as well as to Dr. Jackie Davis, one of my peer mentors, and was very helpful in thinking about this project. And with that, I would be happy to take any questions. Thank you.
Dr. Perkins, I have to say, as a CF dad, first of all, thank you. I'm stunned by what you just reported, and here's why. I've been a CF parent for almost 23 years, and really some of the most difficult conversations I have ever had with anybody have been in examining rooms at CF clinics with doctors, with nurses, and with social workers. So I'm just stunned to discover how uncomfortable all these caregivers are with talking about these things, given, as you just said at the beginning of your presentation, how ridiculously expensive CF care is. So I guess my question for you is, or my suggestion to you is, take the ball over the goal line and just talk for a minute about how unacceptable that is and how it's imperative for you and your colleagues, CF caregivers, to get comfortable. Because if we can't talk about this stuff with you, who can we talk about this stuff with?
No, I think thank you for raising that point. I think you're absolutely right. These are challenging conversations for us as clinicians. I think as in our training, we get lots of education about, we give this medication or this is the physiology, but thinking about, cost or how health insurance works, this is not really training, unfortunately, that we get during all of our training. I think many of us in this room, though, that are clinicians are believers in this and are engaging in these conversations. But I definitely think there's additional work that we have to move forward with in the best interest of our patients and their families.
So I've been a CF clinician for a while, way too long. But all the stuff that I'm hearing today is more about clinicians on the effector arm as opposed to the affector arm. And what I mean by that is CF as a community, I'm sorry, I'm going to get yelled at for what I'm about ready to say. We have not been good stewards about how we manage resources and prescribing in and of itself. There was a great article, for example, by Elliot Dazenbrook about a decade ago looking at inhaled antibiotic therapy that's obviously pre-modulator, showing people with like FEV1s over 100% or on multiple inhaled antibiotics, right? So there was talk at the time with Bruce and everything else for choosing wise to participate in the Choosing Wisely campaign, which the foundation said no to. And so my question is, where is the responsibility, and do you have data even from your own surveys? How much do physicians actually, A, know the cost of what they're prescribing, and B, understand financial toxicity as part of the risk benefit for actually deciding on what screening tests, what medications to prescribe, and how is this information going to be integrated into the new care models? Because if not, you're basically saying, do what you want to do anyways. It doesn't really matter. And what we need to do is train you to be able to help people overcome the financial toxicity that you are actually causing in the first place.
Thank you. That's a terrific question. I really think there's probably three parts to that question.
Yeah, no, it was a long one. I totally get it. I totally get it, but like...
The first part, though, as a clinician sort of being on the front line, and prescribing some of these medications, we sort of broadly know they're expensive, but on an actual dollar and cent sort of basis, we don't know. And some of the EMRs can give us an approximation, but how accurate is that? And to your point, I think we need better decision aids in terms of integration into our EMR or understanding about what that actual drug will cost. So that's the first part. Remind me your second question.
No, I think it's just a question is whether, when and at what time is the foundation and our society going to do our version of choosing wisely, determining when we should be de-adopting certain things, what is true waste within the system so that we can actually be partners in reducing financial toxicity as us as the affector arm as opposed to the effector arm talking about it.
Yeah, no, that's a terrific question.
I set you up for that. I could let anyone here comment on that.
Ryan, can I throw you a lifeline, though? And I think
yeah, sorry, Greg.
One thing that Ryan is not mentioning is he and our team in Boston has worked with folks at Harvard Business School looking at the concept of value-based care. And we have started to do some health economic modeling with colleagues across the pond in Ireland, looking at our current system, comparing it to what in Ireland they're setting up. The impetus was there was a health economist in Dublin. They were helping set up a new CF program in one of their hospitals, and they had an economic evaluation of what they were doing. Faculty at the business school sort of brought us all together. And so you are doing this work, and we are doing this work to look at sort of the current value stream, and then we have to think about where the inefficiencies are. So, sneak peek, there will be likely a publication coming out in the New England Journal of Medicine Catalyst about this work, comparing economic impacts. And that's not saying that's the answer to your question, but we have to understand where the value stream is right now, and then we need to bring people together to say, where are the inefficiencies and what can we do? And I actually do agree with you that in the care model discussion, we need to think about financial issues as how that integrates. Because if we're adding team members, but we're losing revenue on one side, the balance is going to be off. It's not going to work. And I think we really do have to think about that. So I think this is why we bring people together like this at the conference, because we want to start those discussions.
And I'm just going to make a quick comment, a follow-up to our first commenter. So if you look at medical school curriculum, for me, in my own career, it wasn't until a few years ago that I started really thinking about costs of care for all of my patients, and I had to go out and get extra training. And it was a master's, which I think the idea of a clinician going back to school to have to learn additional information can be quite overwhelming. And then the other thought that I have is that if you look at the tradition of the CF Foundation, it was decades ago we started looking at that there were differences in care across CF centers, and we created a learning network so that we could start addressing nutritional issues and lung function issues more consistently. And I think this is an excellent opportunity to go to the learning network with this information and start going, how do we start putting together quality improvement projects to start helping clinicians, the whole care team, have these conversations and start to integrate it just as we integrated and standardized care around nutrition, lung function, pulmonary exacerbations.
I think that's a great idea.
The specialty that comes to mind that deals a lot with expensive medications and financial toxicity is oncology. And in my limited time in oncology clinics, they do have patient navigators whose role is specifically to discuss with patients costs of care, how to deal with the insurance companies. Is there any thought, like in the CF community, about evolving the care model to include and integrate patient navigators?
I think
like
that's
to answer these questions that social workers and physicians are really not equipped to handle.
I think that's a great point. To answer your question, I do not know if that's been part of the model that has been considered. I will just put a quick plug in tomorrow. There's a session about keeping care accessible and sort of the cost appropriate per se. There will be a speaker there who will be talking about some of the care models. So that may be a question I would punt to that particular. But I think it would be a valuable role.
Mary, go ahead.
Hi, Mary Dwight with the CF Foundation. I would add to that, I think the concept of patient navigator has absolutely been discussed. And I think as you all were talking about, the complexity is where does that sit, right? And how do we pay for that service? I think the default now, which I'm not saying is the right solution, but the default is Compass, right? That is the tool that the foundation makes available for all care teams and all patients and families to help with a lot of these conversations, a lot of the tools you saw Ryan share are Compass or generated. So it's about bringing the conversation and having an ally and an expert in the issues of cost, health insurance, navigation, et cetera. So we are 20-something people, case managers in Compass. That's far from the complexity of the care network. But we do know that we touch a significant portion of the CF population annually. And there's a lot of great posters and research coming to be presented in sessions about the impact of that. So I'm not saying it's sufficient, but I am saying that it's it is what's there now in the form of navigation.
Thank you, Mary. And actually, I probably don't need to be up here anymore because I was thinking patient advocate as well, or navigator, while you were talking about this. You had other in there, so I don't know if other maybe falls into something like that. As a mom who received a child's diagnosis, never done anything with the medical field at all, that was the single most, next to getting a life-changing diagnosis to my child, terrifying thing for me was, what am I going to pay now? What's going to be this cost? All these things. And we were fortunate. I am incredibly fortunate to have just a phenomenal care team that I know not everybody has as much of fortunate as I do. They seem like they know all the answers. But I'm also someone who asks the questions, and there are patients, and I'm sure physicians here don't even know what questions to ask. There's been times I've gone to a pharmacy, and the pharmacist told me it was going to be $40 for albuterol. And I said, no, run my insurance again. That can't be right. I don't pay for albuterol. It's covered. But without me knowing that, I would have paid and walked away. And so how many times we're having these pharmacist errors, and I'm telling you, this has happened many, many times. I also work at the grocery store with the pharmacist, so I look at them and I say, no, try again. Anyway, but so the patient advocate thing, and I know that there's Compass, but there's something about, and I live in the world of technology, just that extra step of having to go reach out to somebody that is so challenging, especially when you have all these other things going on. So I want to echo that. Thank you for everything you guys are already doing. Mary, I appreciate you bringing that up too. So.
And I will say in our data, if people identified as a different clinician subgroup than the ones that I mentioned, we did ask them to report what type, and we did not, I don't think we had anyone identify as a patient advocate or a patient navigator in our study.
Thank you, and thanks for the presentation. So many interesting points in there. I think one thing I wanted to say was just thinking about the previous question about kind of value for money and cost effectiveness within treatment and care decisions. I think particularly when you're looking at that study that you're doing with colleagues in Ireland, I'm an Irish person here in the room, so particularly interested in that. Is really important when those studies are being done is just to reflect on the fact that the prices that are shaping those calculations are not absolute. They are not fixed. They can be altered, and they can therefore alter what is a cost-effective care offer to a patient and what isn't. And I think the point that I would like to make is within that context, thinking about that reality, that as well as that role of kind of like a counsellor and guidance from clinician to patient, there's also a role for leadership and advocacy. And I've been amazed at some of the people within the CF community that have stood up and said no whenever it comes to some of the prices that are being demanded for medical products for this condition. And just an encouragement that if you want to change some of these cost calculations, if you want to do something about some of the financial toxicity that patients are facing, there's a role for caring and communication with patients. There's also a role for standing up bravely and saying this is unacceptable and that the prices need to change and we need to take action against those people and those actors that are putting those high prices onto the healthcare system.
Yeah, I think we're very fortunate in CF that we do have such a strong, advocacy both from clinicians and from patients and their families and from the foundation. So I think that's an excellent point.
Thank you, Ryan. I'm going to throw one other thing out there as we transition, I think, to a nice segue. We should probably, as a community, start thinking about the financial vital sign as a possibility in CF. I mean, we talk a lot about how to educate people and educate clinicians. I think if we could come up with a way that this information is shared across the care team in a standardized format, I think we could learn a lot. And so I'll put that out there now and we can think about it. But I think, in hearing these discussions, that's something that's certainly top of mind. But thank you again for your work.
And I just want to make one other comment in response to the mother who spoke. When she talked about being able to advocate at the pharmacy and say, no, I don't pay $40 for albuterol. There's other data that I can't quote right now that shows that there are significant cultural differences when somebody, in daily interactions about different cultures will not stand up for themselves. And so we have to think about the equity because CF is a diverse disease, and think about those implications also. So I think with that, I'll just go ahead and introduce the next speaker. So unfortunately, Karen Carey was unable to attend. So we have Kristen Clem, who is filling in for her. So she is part of the Outreach and Inclusion program, and she's a program manager with the CF Foundation and has been with the foundation for the last 7 years.
Thank you. Good morning. My name is Kristen Clem, and as you heard, I'm here on behalf of my colleague Karen Carey, who couldn't be here today. Karen led all of the work that I'll be speaking about, along with the Health System Innovation and Navigation team and the COMPASS team at the CF Foundation. My pronouns are she, her, and I have no disclosures. So many thanks to our session chairs for the chance to be part of this important conversation today, along with some phenomenal collaborators. So thank you all. So I'm very excited to share the thematic work that our team did to identify points of financial vulnerability for people with CF. In a quick summary of the methods, we started with a landscape analysis to identify financial wellness frameworks from other disease groups. We reviewed insurance and financial assistance data. We validated and prioritized points of financial vulnerability, and we developed a model to inform future intervention strategies for people with CF. When we talk about financial toxicity in CF, or the cost burden that comes with living with CF, what we're ultimately talking about are the trade-offs that people have to make every day. The data that you're hearing about throughout this presentation, or in the session really, reminds us of what those trade-offs look like. So for our abstract, we went back to the 2019 health insurance study, which you heard about earlier, some of which you heard about earlier. And you see here that what some of those trade-offs look like. It could be trade-offs made between food, rent, transportation. It could be trade-offs between the here and now or the depletion of any sort of financial cushion for the future, and trade-offs to life plans because of the cost of CF. So our data came from CF Foundation COMPASS cases. For those who may not know, I mean, Mary went into much more detail than I will right now, but it's a free one-on-one service of trained case managers who help they can help clinicians, all of you, they can help your patients, their families, to navigate insurance, connect to financial and other resources, and a lot more. So here's a little bit of the data in a 3-year retrospective of calls to COMPASS, where the initial inquiry came from either a person with CF or a caregiver, and their inquiry was about help affording medication. So you'll see an increase over the 3-year period. It's important to remember that COMPASS data is about calls to the program, and it's not necessarily representative of the entire CF community. And perhaps some of the increase here could be attributed to people knowing more about the COMPASS program. So over this same 3-year period, we are now looking at inquiries related to medical or hospital expenses. Again, we see an increase over that 3-year period. And then finally, again, the same 3 years showing requests for help paying for insurance premiums. So we've established an upward trend here. The almost doubling of inquiries across disparate areas that boil down to affording CF. This underscores a really important point, which is that the need for help is not going anywhere but up. I have 2 additional pieces of COMPASS data that I want to share that I think you might find interesting. This is a 1-year review from 2023 of cost-related inquiries to COMPASS by age range. You could label these groups generally. I have a mouse. So this first group, pediatric, this group, young adults, these adults aging with CF, and then this last group is 65 and older, which is when people can age into Medicare. Please note these blue bars, the inquiries across age ranges for help affording medications, and especially look at this young adult group, how many inquiries we saw there. So next comes a drill down into those medication expenses in 2023, the blue bars from the previous slide, but this time by income brackets. So you'll see that the under 30,000 income range had the most calls for households of 1, and that's not just one person with CF in that family, but think 1 total in the household. And then note the other 3 highest. So we have up to $50,000 and household of 2, think maybe a person with CF and a spouse, up to $75,000 in a household of 3, and over $100,000 for a household of 4. So we'll acknowledge the importance of federal poverty level later on, but the point here is that income is not the only indicator of cost burden of CF. Managing the financial toxicity in CF care is not just simply about making more money. Okay, so with that COMPASS data, we work to identify when financial wellness can be particularly vulnerable for people with CF, and then validated and prioritized those points with our community and clinician-driven committee, the Financial Wellness Advisory Committee. So this committee is made up of adults with CF, clinicians, caregivers, and together we also explored additional financial considerations specific to CF to establish themes. So here are two of those themes. Right off the bat, what it means to thrive and what it takes to thrive are different for every person with CF, so every person is an individual. Second, there's an opportunity to engage in conversations about financial wellness that are rooted in dignity, no matter income, no matter insurance, and no matter where a person is in their CF journey. So next came the framing of points of financial vulnerability for people with CF, which we're going to call transitions for the sake of this presentation. These are the points when the financial supports that a person relied on up into that transition are either strained or completely lost. And the committee named 8 of these points. So new diagnosis for a child, transitioning to independence or young adulthood, balancing life demands as an adult with CF, which we like to call adulting, age-agnostic disease progression, receiving a new diagnosis as an adult, transplantation of any type, return to the workforce, which could entail coming off disability, and then finally turning 65, again with that aging into Medicare part of the paradigm shift of aging with CF. So another key theme is that CF can have short and long-term impacts on income and lifelong impacts on expenses. So we can better understand this using those points of transition from the previous slide as our examples. So here are a few of the CF-specific impacts to income, and I'll share more on the next slide. So for example, when a child is diagnosed with CF, do childcare needs dictate that one parent leaves their job to stay home? A young adult with CF is transitioning off Medicaid or off their parents' insurance coverage. Are they prepared for it? An adult with CF is trying to manage big life decisions like family planning, a career, but also looking ahead and considering if working years and the ability to save could be truncated by future health status. Like I mentioned, here are some additional examples of short and long-term impacts of for the additional points of transition. And this is not meant to capture everything. In fact, I hope that while you're looking at this slide that you'll think of some other examples. But I want to ground us in the reality that expenses for CF and expenses for life all come out of the same pocket. And I think that's a really important takeaway here. So for our final theme, a reminder that financial wellness isn't just about a box that you can check one day. Throughout it all is the combined navigation of 3 different elements that are especially important in life with CF, and that's access to care, cost of care, and health-related social needs. And individuals or a family's finances can be impacted by hardship in any one of these 3 categories. So that's another thing that we need to remember. And that underscores the importance, but also the challenge of planning ahead. So here we are at the tool to help recognize those transition points, the challenges, and then to tailor interventions based on tailor interventions to address the financial toxicity or cost burden that people are experiencing. So the framework starts with opportunities to mitigate trade-offs that are either reactive or proactive in nature. So from this reactive and proactive dichotomy, we have 2 questions. First, is the individual experiencing financial hardship? And the key here being a hardship that they have prioritized, not something that you or I have prioritized for them. And then second, how equipped does that individual or family feel to handle that challenge? So the questions are up here again, but flagging those 3 categories I mentioned earlier, healthcare access, cost of care, and health-related social needs. It's really critical to think about with these questions. So in individual or family's hardships and the extent that they're equipped to handle that hardship can really fluctuate between those 3. So as I wrap up, here are 3 examples that are neither associated with the data nor representative. They're simply food for thought. So each of these random scenarios could present an immediate opportunity for a reactive intervention, or the discussion that the tools allow for helps us to consider some potential proactive interventions that could help mitigate future or further financial impact. So starting with this first example, a family of 3 with a child with a new diagnosis, families making $75,000 a year, that's 290% FPL, which may determine their eligibility for local, state, or national resources. So thinking of this family, you may already have some resources in mind that you would suggest to help them meet anticipated expenses. For example, the new medication that their child now needs that they've been diagnosed. But consider too the value of looking proactively ahead to next year's insurance offerings to make sure that what the family needs now that their child has been diagnosed is covered. Things like their care team being in network, potential medications on the formulary. Or take this second example, a household of 1 making $30,000, that's 199% FPL. Maybe this person is just starting out in terms of their employment path. Perhaps they don't have much of a financial cushion. There is a proactive opportunity here for cost of care conversations about things like maximizing benefits and tapping into available resources for some anticipated expenses. And building the knowledge of the cost of CF care here is really an important part to helping this individual feel equipped for their future. And then our final example, a household of 4 making $105,000 annually, that's 503% FPL. And in our scenario, the person with CF has recently been hospitalized. So there may be resources to provide to support this immediate incurred expense for this family, which is that hospital bill, but there might not be because this family needs help, but due to their income and their family size, they might be over income for the resources that exist. So what are some proactive opportunities to think about for those short-term impacts CF might have for this family? Are there other types of financial assistance that could help free up room in this family's budget for bills that, like the hospital bill, or others that will prevent them from having to make financial trade-offs in the future? So to close, here are some resources from the CF Foundation across those 3 different areas: access to care, cost of care, and health-related social needs. There are resources that you can watch, like our Navigating CF video series. There are resources that you can reference, like toolkits and the new cost of care discussion aid, which we heard about in the previous presentation, and ways to connect people with CF with their peers for peer support. The hope is really that these resources can help you and your patients engage in conversations that are rooted in dignity, about financial barriers, about avenues for assistance, and then that both you and your patients feel empowered to look proactively at the next step. So if you're interested, you can scan the QR code and it'll take you to a form. And on that form, you can indicate your interest in learning about CF Foundation support connection and partnering programs, as well as educational resources on this topic and others. And with that, I will end my presentation with a special thanks to those listed here, especially Sherry Williams, and all of these individuals listed here for their contributions to continuing this conversation. I am happy to take some questions now, but I did want to share my colleague's contact information, because she is much better suited to answer questions about this work than I am, but I will do my best and potentially rely on my other colleagues here if there are questions. Thank you.
Hey, Karen, that was a really beautiful presentation. Thank you so much, and thank you for addressing these issues with CF families. My name's Travis Suit. I'm the executive director for Piper's Angels Foundation down in South Florida, and we work directly with Compass. Compass sends us referrals for CF families each year. We have an urgent financial assistance program, and last year we issued 149 urgent financial assistance grants. This year that number will have, thank you. This year that number will have grown by 25-30%. It's grown every year, and as a small organization, we obviously stretch for resources to meet these needs, and our grants are often between $300 and $500, sometimes more if it's for transplant. A couple questions. One is, what resources in terms of the CF Foundation are available for organizations like ours that could support us with funding for more of these urgent financial assistance requests? Mm-hmm. That's one question. And the reason I bring that up is because it just seems like year after year after year we see these, and just like perspective-wise, we're $1 million organization, but we're being sent referrals from a multi-billion-dollar organization. And I just would urge CFF and the CF community as a whole to look at the resources that we have available, because this idea of urgent financial assistance is, it's really pressing. And many of us sitting in this room don't have to deal with it, but we deal with people who do deal with it. And so I just want each of you to know that there are resources out there, and I want you to know how much we appreciate that you help us do our job better. And that's what we just want to do more of. So I just want to present that as an open-ended question that, maybe next year at this time, at the conference, we'll have better solutions, answers, and resources.
Yeah, thank you for that question. Thank you for everything that you do.
I am struck by the data, that just shows the real-time increase in the number of people that are contacting Compass, and I think that's probably a reflection of better integration and knowledge across the CF care centers that Compass exists. Yeah. I also recognize, though, that it is a selection bias of those who know about Compass or are with teams that know about Compass, and I think in particular, just want to, do you have any, and maybe you or others in the audience know, data on, how the sort of demographics or the background of people that are contacting Compass? Are we really missing those that are in marginalized communities, low literacy communities? We talk a lot about social factors influencing health, but if we're not reaching them and they're not reaching the resources, we're missing a big place. So I don't know if Compass captures that kind of data or is even able to share that, but I think we have to recognize that we probably are missing a vast swath of individuals and families that don't have those resources.
Yeah. It's a great question, which I can't answer, but I'd love to ask one of my colleagues.
Putting Ann on the spot, sorry.
But I do want to also share, while she's on her way up there, that Compass does have a lot of resources which are available for you to order, so you can have them in your clinic, like flyers, like pill boxes, different things that you can have available to hand out to your patients, so to make them more aware of Compass, so you can help us with that. But go ahead.
Thank you. So great question. We are not currently systematically collecting demographic information, particularly race and ethnicity. We recognize that it's important, but also want to make sure that when we collect that, we do so in a way that is appropriate. And so we've been spending the last part of this year looking at how we can best collect that information. Particularly, it's over the phone. We might not have a relationship yet with that person. So we are looking into that. And then I think we don't have the direct data, but we do know socioeconomic status. Sort of generally, we have some indicators of things like Medicaid. We collect income for certain kinds of cases. We don't have it for everybody. So I would say generally we're kind of limited in what we're able to collect. To add on to that, I will say that the Cost CF survey did ask a question about awareness of Compass and if you contacted Compass. So we will be able to look into that, at least for that survey, again, recognizing there's selection bias in terms of who actually responded to the survey, but that's something we haven't had a chance to do yet.
Thank you.
Okay, and our last speaker is Dr. Jonathan Gao, who trained at Imperial College and is currently working as an academic doctor at St. Mary's Hospital in London. His research interest in CF is focused on disparities in access to treatment, particularly the highly effective modulator therapies.
Perfect. So thank you very much for having me. And I'll just start by saying I think it's kind of been covered already, but these topics are very uncomfortable and can be very difficult to talk about, and I hope you'll agree, I do think they're important. I do think they're important, and so thank you all for being here today. So, CFTR modulators have, of course, transformed outcomes in the disease area. but they've been priced by the patent holder, Vertex Pharmaceuticals, at hundreds of thousands of dollars per year. This renders the drugs unaffordable for health systems and inaccessible to patients. So, for example, this is a list published by Vertex of every country where any modulator is accessible. When you stratify these by income status, we can really see that access is exclusively limited, almost exclusively limited, to the richest countries in the world. And it should be noted that access as defined in this list is not equivalent to reimbursement for all eligible patients, as it includes countries where modulators can only be obtained via alternative means, such as legal actions against governments and health systems. So why are prices so high? Unfortunately, drug pricing is a topic that's notoriously opaque, often being described as a kind of black box. And this is especially true in the case of treatments for rare diseases, often known as orphan drugs. However, in trying to kind of make sense of controversial pricing decisions, there are a few common rationales put forward. The first is high production costs. After all, these are complex molecules requiring expensive equipment and processes. A drug can also be thought of to have a higher value if it produces better clinical outcomes for patients. And indeed, this is sort of the main thing considered by stakeholders in health technology assessment. Yet our analyses based upon active pharmaceutical ingredients for ETI and other modulators indicate that minimum costs of production are 90% lower than marketed prices. And cost-effectiveness analyses by national and independent bodies have concluded that the benefits of modulators, while profound, do not warrant their prices, recommending reductions of between 70 and 90%. Which brings us to the cost of research and development, perhaps the most widely cited and compelling of the three. The thinking really goes that drug development is a long specialist process and very, very expensive and costly. In addition, it's inherently risky, with failure rates of up to 95% quoted. Therefore, when products are successful, companies must recoup the large cumulative sums of money spent over many years on their development. And clearly also additional revenue on top of that is required to allow for further investment. And finally, beyond just survival, companies should be rewarded for taking on such risk and innovating to encourage further breakthroughs. Now, all of these factors are exacerbated in the case of orphan drugs, where there are smaller populations, so per patient cost must be higher. And if this didn't happen, then rare disease areas would be neglected and patients would suffer. And these principles are undisputed, but when applied specifically to CFTR modulators, raise three sort of equivalent questions. The first being, have the costs of R&D spending been recouped? Next, are high prices driven by contemporary R&D spending, or in other words, would a reduction in revenue mean less investment? And finally, are we striking the balance between risk and reward? So currently, Vertex's entire drug portfolio holds significant overlap of active ingredient. They're all in the same therapeutic class and represent some of the company's first successfully marketed products. This provides us the opportunity to really make meaningful comparisons between cumulative R&D expenditures and revenues after approval. And with these questions in mind, that's really what our analysis aimed to do. Accordingly, we extracted annual data from Vertex's publicly available SEC filings on R&D spending and modulator revenues. This was done from 2001, when Vertex first acquired the work on modulators, all the way until 2023, with all values adjusted for inflation. We also accounted for what's known as the cost of capital, or opportunity costs, which is essentially an assumption that the funds put into a project were instead put into something else with a flat rate of return. This can really be thought of as a kind of lost potential on money that will be locked up in a project that won't bear fruit for many years, if ever. This was estimated at 7% per year, in line with other comparable analyses and average annual stock market returns. Now, it should be noted there's some dispute as to whether this should actually be included in these sorts of estimates, especially in the case of drug development, as indeed a drug company that doesn't invest in R&D won't produce any drugs and therefore kind of ceases to be a drug company at all, especially in the conditions of our analysis. And for that reason, we chose to include the data both with and without this cost. So what did we find? Total inflation-adjusted spending on R&D from 2001 until Q3 2019, when ETI was first marketed, reached $18.6 billion. Comparatively, since the release of ivacaftor in 2012, revenues have grown rapidly, totaling $58.1 billion. In other words, 5 years after the release of ETI, the company's entire out-of-pocket R&D expenditure has been recouped more than 3 times over. And costs have been recouped even when you incorporate cost of capital, which is modeled at $13.4 billion, notably almost equal to out-of-pocket spending. And when you plot the data annually, we can also see that R&D investment has not increased at an equivalent rate to sales, So from 2012 to 2023, annual revenues increased by 4,260%, compared with an increase in R&D spend of 218% over that same interval. This remains the case if you instead look at spending growth since 2001, or even if you just track the period after 2019, once all pre-ETI R&D spending had been recouped. And when we actually plot the difference between cumulative R&D spend and revenue across the whole study period, essentially the size of that gap pictured there, we can see that this displays an almost parabolic increase since 2015. It appears, therefore, that R&D spending is far from dependent on high prices. There's clearly room for some restraint without fear of jeopardizing innovation. Now, it's important to be very clear that our study looks at total research and development spending, and that the proportion of this actually relevant to modulators will be much smaller. This is because we incorporate the cost of failure and R&D spending on other products. This would include telaprevir, which went to market in 2011, but also all the candidates in the company's pipeline as of 2019. And notably, many of these are novel products in different therapeutic classes, which tend to cost much more to develop than so-called next-in-class molecules. We also didn't account for tax benefits associated with orphan drug development, which can be up to 50% of R&D costs, or the accelerated development process enabled by orphan designation, which allows for smaller trial sizes, expedited approval, and therefore generally lower costs of development. And so this brings us onto that broader question of risk versus reward. So the initial research on modulators was carried out by a different company called Aurora Biosciences, with the support of around $40 million of CFF funding in the earliest and generally seen to be most risky stages of development. Following their acquisition by Vertex in 2001, this went on to become one of the sort of earliest and literal textbook examples of venture philanthropy. Since then, ETI has become one of the highest revenue pharmaceutical products currently on the market, enjoying annual sales of upwards of $8.9 billion. Yet when you compare ETI to the world's other top-selling drugs, it's an outlier, with a market or patient population orders of magnitude smaller than its peers. As a company, CFTR modulators make up more than 90% of Vertex's total lifetime product revenues. And specifically, sales of ETI now represent almost 95% of the company's income each year. Despite this, Vertex has become one of the world's most valuable pharmaceutical companies by market capitalization. And again, is an outlier in that they sell far fewer products, but also in that almost all of their annual revenue comes from one drug sold to less than 70,000 people. Now, for better or worse, I don't work in finance, but valuations are, of course, not just based on a company's current situation, but on future outlook. So looking ahead to the future, we can see that CFTR modulators now have reimbursement deals in most high-income countries around the world. They're lifelong medications with an ever-growing adult CF population. They have no competitors on the market and remain under patent protection for the foreseeable future. Furthermore, they hold potential for label expansion with significant research into use in more age groups and mutation profiles. However, even if we were to disregard all of this and assume that annual revenues were to stay at current levels, these would reach at least $192 billion by patent expiry. In the context of another modulator combination expected to market this year and future genetic therapies, this brings us to kind of a different question, pertinent both now and for the future. How much is enough? Longitudinal research has demonstrated that health system savings from the reductions in exacerbations, hospitalizations, ED visits, and cessation of other treatments are outstripped by medication costs of ETI almost 10 to 1. And we can see the real-world resource allocation dilemmas this poses via the protracted negotiations that have preceded almost every reimbursement deal for modulators. So, for example, at the end of 2020, a year after initial approval, ETI was reimbursed in just 6 countries around the world. And being a highly emotive topic, discourse around these negotiations often, unfortunately, becomes distorted, pitting patients against governments. It therefore seems a rather daunting prospect if people with CF will have to fight this battle with every future innovation to come. Following the advent of modulator therapy, the top research priority for people with CF has become providing options for those unable to benefit, to ensure no one is left behind. This includes the small but significant proportion of people with mutations rendering them ineligible for current modulators. Now, it's widely accepted that there are relatively small numbers of people with such mutations in high-income countries, representing a significant challenge for R&D and clinical trial recruitment moving forward. Simultaneously, such mutations are far more common in lower middle-income countries. However, under the principles of research ethics, it's unacceptable to ask patients to assume the risks of a trial if they don't stand to benefit from the results. This makes it difficult to run trials in countries where an originator company may not intend to provide access in the future. And this is reflected in the choice of countries involved in the pivotal trials for ETI. In this way, the mechanisms that were initially designed to encourage drug development could actually hinder future innovation. And now I'd like to show you this series of figures I saw in a recent Nature article showing changing trends in CF. In particular, I'd like to focus on these two graphs, depicting the increased life expectancy afforded by modulators compared with basic supportive care, and disparities in median survival internationally. Inadvertently, I believe that these figures really demonstrate the potential impact of inequitable modulator access on existing health disparities, with average survival in some LMICs equal in length to the typical patent protection period of around 20 years. As we enter a new era of CF treatment, we risk also entering a new era of inequity, the magnitude of which could become a defining feature of the field. So what's the current outlook of global modulator access? Over a decade after their first release, Vertex recently announced a donation program in partnership with a charity called Direct Relief to provide the drugs in 12 countries. Now, any measures to increase access should be celebrated. However, it is difficult to see the rationale behind the choice of countries included in the program, appearing perhaps to be driven by perceived commercial viability rather than disease burden. So, for example, there are no known cases of CF within the literature for several of the 12 included countries, whilst others with significant patient populations and where Direct Relief already operate are left out. So what are people doing in these areas? So in Uruguay, around 80 people have managed to gain access to ETI through individual legal actions taken against the state at a cost to the health system of $22 million per year. In South Africa, after legal proceedings aiming to secure a compulsory license for ETI, a deal was agreed granting access for patients with top-end medical insurance, representing around a third of the total eligible population. And this really represents the situation in just 2 countries. When you compare the scope of the current donation program with the scale of the problem, it becomes clear it's fundamentally insufficient. And after 12 years of little meaningful action to address inequities in modulator access, it's difficult to ask people with CF in these countries to wait any more in good faith, while at the same time watching others live longer, healthier lives. Clearly, something more is urgently needed. Similar disparities in disease areas such as HIV and hepatitis C have been addressed using voluntary licensing, wherein generic manufacturers are permitted to market drugs at close to cost price in resource-limited areas. Rather than individual patchwork compromises, this policy balances financial reward with sustainable, equitable access and would cost marginal sums of money in the context of contemporary and historic revenues. Indeed, it's a policy already used by many of the company's peers who continue to be able to innovate and grow. And it's equally viable in this setting, with Vertex themselves estimating that loss of market exclusivity and entry of generic competitors would result in price reductions of 90%. So to circle back, how much is enough? What is fair? Unfortunately, that's not a question that I can answer for you today. But the coexistence of these two realities is difficult to reconcile, with protections and incentives initially put in place to encourage innovation being used to restrict access to those most in need. And ultimately what this translates to is more exacerbations, more hospitalizations, worse quality of life, and a death years earlier than necessary. Now, with issues on this scale, I find everything can really become quite abstract. It's difficult to conceive of tens of thousands of people or billions of dollars of money. And so to conclude, I'd like to hand over to my friend Erte, who's a CF parent from Lithuania, where there's no access to modulators, to share her lived experience of the issue. But before that, I'll leave you with this. By this point, I will have been speaking for around about 14 minutes. And in that time, based on Vertex's 2024 projected revenues, the company will have made around $300,000 from the sales of modulators, mostly ETI. It is of course vital that transformative discoveries are rewarded, but this cannot and need not come at the cost of the health and lives of people with CF.
So unfortunately, I'm here again. I was almost at the same place, just different city in Phoenix a year ago, sharing my story about what it's like to live without the access of CFTR modulators. And unfortunately, the situation hasn't changed. We still don't have access to this miraculous drug. And the fear and anxiety we have to face every day is still among us. The day I flew here, my daughter got sick. And as a parent, I had such a huge anxiety about how her life will be and if she get complications or not, if she'll be okay.
And knowing that there is a drug that could change her life, lots of kids' lives, and it's impossible to get them because of the high price. It's just devastating. And it's not only our reality, it's many, many people, many kids suffer because of that. Many kids are dying right now at this moment. Many parents losing their kids. And this injustice has to be stopped somehow, some way. I urge you, all of you here today, to stand with us, stand for, not only for Milda, but for all the kids around the world, because you can do a change as well. Not only us parents, you can make a change. Let's make sure these life-saving treatments are accessible to every child around the world, regardless where they live, their financial situation. This financial toxicity has to be stopped. Thank you.
My name is Fadi Asfour. I'm a pediatric pulmonologist from Salt Lake City, Utah. I have been working with CF centers in Jordan. It's also a low middle income country that does not have access to CFTR modulators. I think it has been amazing for us practicing in the US and some Western countries to see how remarkable CF lives have transformed after a CF modulator. It's also heartbreaking that there are far too many people with cystic fibrosis that do not have access to modulators around the world. I think it's really just not okay, because life should come before profit. And also, we are here to help everyone with cystic fibrosis, not just the one who can afford outrageously crazy expensive medication. I will be joining the protest right after the session. I invite everyone to come. We'll meet outside at 10 a.m. We'll walk to Vertex. We'll just let them know this is not okay. We need your voice, we need your presence. And I think the time to act is now, because CF patients are dying and they cannot afford just to keep waiting. I think every week or 2 weeks, I feel like we get a notice of someone who died internationally who could have, their life could have been saved by the medication. So I think you can do something. We have done a lot for our patients in the US, but I feel like now it's time to help beyond our centers, beyond our patients. So I invite everyone to join us right after the session. Thank you.
This is very close to my heart, but I got a message from a mother just this morning from Iraq, and she asked that I would raise her voice. So she texted me this. She said, can you say that there are patients in Iraq who do not have the simplest medicines, not even Creon, and then we don't have modulators. She has a young daughter who's 4 years old, the same age as my daughter, and I am so beyond privileged that my daughter gets all this medication. Trikafta shows up at our door automatically, and I can open the door and I don't pay a dime, okay? And she can't have the basics. I am going to be going to the protest because I think it is incredibly important that we raise these voices to these patients across the globe, and that when we really believe that we will not stop until a cure is found, that cure is not just for us here, that is globally. And if we cannot figure out how to get medications to patients globally, how are we going to get a cure to them globally? So please join us, 10 o'clock, we're going to meet and we're going to walk to Vertex, because they have the power to save lives. Thank you.
Well, I mentioned difficult conversations earlier, and now here we are having one now, and I'm very grateful. I'd like to actually ask you a substantive question that goes back to some of the earlier slides that you show. I am a CF dad, but I have a day job. I persecute public utilities for a living, like Eversource, the local one here. And so I know a little bit about monopoly pricing of essential public services. And the analysis that you undertook at the beginning of your presentation is similar to the way a utility regulator would price the cost of electricity or natural gas or water. But I would make 2 points about that. One, I think your cost of capital of 7%, I mean, that's comparable to what we let utilities make. And public utilities are a way lower risk business than what Vertex Pharmaceuticals is doing. But my question for you, you glossed over, or you briefly mentioned, I guess, the analysis that the Institute of Clinical and Economic Review did of Trikafta. They do it a different way. They're not measuring the supply side cost of making the medication. They're looking at the incremental value of the drug, and their report, which they put out, I think, about 4 or 5 years ago now, said that Trikafta is overpriced by at least a factor of 3, that a fair price would be somewhere in the $80,000 to $100,000 range, at least here in the US. So I wonder what you think of that method of analysis and whether you think ICER got it right.
Yeah, so I think there's different ways to look at it. I think that's what I tried to sort of briefly cover. And I know there wasn't a lot of time, but I tried to cover sort of the main arguments that are put forward and the main sort of reasoning behind the pricing. I think what I've seen from, there's different methods around the world, but it seems fairly unanimous that there hasn't been a single health technology assessment that has said, you know, the price is right and we should just go ahead. I think that's quite telling. And I think that's seen in the fact that it takes years in many countries, even some of the richest countries in Europe, or highly developed economies in the world. In the UK, we just had another outbreak of that in this year actually, where the regulator said they may stop access for new patients who become eligible, which would have had this weird situation where you have people who were eligible back in 2020 having the medication, but then anyone who became eligible, so over 6, over 2, would then not get access. So I think this is a continuing thing. The health technology assessment view on it is one aspect. I tried to sort of cover another thing that's often put forward with this, just to have a look at that and examine that a bit more. I couldn't say the best way of doing it, but I think that most of the approaches come to a similar conclusion.
Thank you.
Dr. McGarry.
Hi, my name is Dr. Megan McGarry from University of Washington. So with all these numbers, I think it's really important to remember how we got here. So we got here because moms had their children dying with CF, and they said that's not acceptable, and they formed the CF Foundation. They didn't just form the CF Foundation, they demanded CF care centers, they demanded that that there would be innovation, that there would be drugs developed. Those moms, over the last decades, have fundraised, taken their time out from caring for their child and fundraised. When their child died, they fundraised in memory of those children. That money is what has funded the CF Foundation, many of our research, our careers. That money is the research, funded the research that developed CFTR modulators. We need to continue to stand with moms who are continuing to fight for their children to live, because there are moms around the world, there are moms here at this conference, there are moms in the United States who do not have modulators for their children, and they want their children to live. And so we as a community need to respect decades that have built our careers, our research, this community, and stand with these moms now. Come please stand with us and let Vertex know that $10 billion in cash on hand right now, $10 billion, they could change it overnight, and they refuse. Make them listen to the moms of children with CF. Thank you.
Hi, I'm Brian O'Sullivan from Dartmouth. A group of us back in 2012 actually met with Jeff Leiden and the people at Vertex to share our concerns about the cost of, at that point, Kalydeco or ivacaftor. We had a very nice discussion with them, and months later, the price went up about 10%. So you can see how effective we were back in 2012. This is an issue. And I don't really have a question, just I want to say the work you guys have done and the slides you present are just so important and so wonderful to show just how out of range and how unconscionable this is. And I did have the opportunity, Don and I both have sat with the ICER group and been part of the New England committee that reviewed and approved their comments. So it's been something I've been working on for a long time and with Megan, and we've got to do something. This is just, and I think, Don, did you tell me something like only 19% of people with CF who are eligible for this drug around the world are getting it because it's just not available in so many countries, and this has got to change. So thank you very much for all you did. Thank you.
Hello. My name's Gail. I'm a CF mom as well. I'm a founder of the Right to Breathe campaign. As Megan was saying, I speak to mums every week from countries around the world. I can't tell you how many WhatsApp groups I've got with mums who are suffering every week. It breaks my heart every single week. So I'm really honoured to be here with Urte and Pratibha, who will also be presenting tomorrow. I invite you to come to that. It's heartbreaking, but it is the reality of families that don't have access. So I'm asking you now, I know you've probably gone to a lot of conferences, you will go to a lot of conferences, but today you have one opportunity to stand with these mums and come with us. We just want your time for an hour. Come with us now. We are leaving to go to Vertex with a petition with 140,000 signatures, and we need you to stand with them. Thank you.
Hi, sort of a technical question. So last year, Janssen Pharmaceuticals, under significant public pressure, declined to enforce their patent on Bedaquiline, which is the only available treatment for multi-drug resistant.
Sorry, I can't hear the question very well.
So declined to enforce their patent in countries with high burden of multi-drug resistant tuberculosis. Is that a model that could be effective in increasing access to Trikafta in low to middle income countries?
Sorry, I didn't quite hear
Sorry.
the aspects of it. Do you mind?
So last year, Janssen was going to extend their patent for Bedaquiline, which is the only drug that's available to treat MDR tuberculosis at the moment, and under significant public pressure decided not to enforce that patent in specific countries that have high burden of that disease and low income. Is that a model that could be effective in increasing access to Trikafta in low to middle income countries?
Yeah. So I think definitely. I think one of the things that looking into it I've noticed is that many of the top pharmaceutical companies in the world they make arrangements that allow for broader access in the most resource-limited areas, and that's had a tremendous effect in many different areas with similarly game-changing drugs. So anti-ARVs in HIV, DAAs in hepatitis. And those companies are still the richest companies in the world. They still make a lot of money. They still innovate. They still produce groundbreaking discoveries. So yes, I do think so. There's no one option that is the best way forward, but I think something needs to be done. And in the current system, the way that it is, all the cards are in one hand, so to speak, with the way IP law and things like that work. Which is why I think it's so important to have that discussion. And the thing that I should say is that the first modulator was released in 2012. There was no real measures really done for the past decade. Some small compassionate use programs for those who were most sick in countries that were having negotiations, but I think that was pretty much the extent of it. And now we're having more measures. Yes, it's not necessarily what we'd like, but at least there is something being done now, and I think that's in no small part to the actions and sort of conversations and everything that we've been doing as a community, and I think that's why it's so important to keep going.
Yeah, first of all, fantastic talk. And the one thing I would say, in addition to what is truly a worldwide travesty as to what's going on with the ability to get these medications within the US, how these medications are bankrupting a lot of state Medicaid budgets and Medicare, and realizing that there's sort of some broken issues within our pharmaceutical industry, kinda. But one of those is actually price collusion and generic up pricing. So for those who may not remember, 10 years or 12 years ago when the only inhaled antibiotic was Toby, it was about $4,500 a month. Generic Toby now is almost $6,800 a month because as each inhaled antibiotic has come to market, they've priced it higher, and then everybody else raises to match, sort of like airplane bags. This is most notably known for multiple sclerosis, where interferon beta was only about $20,000 a year. Now it's over $1 million a year, right? Because each one that's come on the market has priced itself increased. So while we may want to get patent protection taken away earlier and getting more drugs to market, that won't necessarily solve the existing price problem that we have within this country based on what we've seen with every other market class and medication.
Thank you. And again, thank you to all the speakers for this session. I just want to close by saying a couple things. One is thank you for listening to all our speakers and hearing and starting and engaging us in what I think has been an incredible, not just set of presentations, but discussions with the audience. And I think you don't always get that in conference workshops. So I think thank you on that. Number two, to continue this discussion, there is a symposium tomorrow afternoon specifically focusing on cost of care and the care model. We're also including a speaker who's coming from the non-CF space to talk about costs when we think about gene-based therapies. So we had a great plenary yesterday about the promise and the excitement of science. There have been gene therapies approved for other conditions, notably sickle cell disease this year, which are priced at millions of dollars. And so we need to be prepared for that as a CF community. So please come join us tomorrow at the symposium to start thinking about that conversation. And I think take this information, we're not the 5,000 people and attendees here, and move it forward. Advocate with your care centers to think about these topics. And also think about it locally in the community. We have an election coming up, and I'm going to take prerogative as a workshop leader here in November. We have a chance in the United States to make a change and continue on a path of actually equitability for our patients and thinking about taking on the drug companies and working about value and care. There's one option that is clear and one option that is not. And I'm just going to take this prerogative to say that. So please, if you know people who aren't, and many of you live in states where this matters. I live here in Massachusetts where my vote counts, but it doesn't count as much as my colleagues in you know where you are states. Please make it happen. And thank you again for attending.